Professor Utpal Dey, Professor of Surgery at NRS Medical, you will moderate. And our third year junior resident, Dr. Milind Dalogji from Ever Mangur will present. Milind, you can share the scenario and go for discussion.
Sir, Nitesh is presenting, sir.
Oh, Nitesh, sorry, Nitesh present. Okay.
Good morning, sir.
Good morning. Please.
30-year gentleman came to ER with generalized pain abdomen. He has a history of skipping meals and intermittent episode of pain abdomen. On examination, 69 mm Hg. Pulse rate is 134 per minute. Respiratory rate 32 per minute. Per abdomen, rigid abdomen, and IPS action. How will you proceed?
Okay, so this is the case scenario, isn't it? So you are in the emergency. There's a 30-year-old gentleman who is presented with generalized pain abdomen. Then he has a history of skipping meals and intermittent episodes of pain abdomen. Okay, right now. So on examination, you have found this. Now, do you want to take anything else you want to ask in the history of this gentleman? Suppose you are in the ER, so this patient has come. So do you want to take any further history of this patient?
Sir, as per scenario given, the patient is suggestive of perforative peritonitis and patient
No. Nitesh, don't jump to diagnosis. You have been asked whether you need to elaborate further on the history.
No,
I am not happy with the history. I want some more information to come to a provisional diagnosis.
Sir,
see. Are you happy with the history and proceed for management, or you want some more information to be obtained from the patient?
Sir, some more information to be obtained, sir. But sir,
so what are those? What are those? That is what I am asking.
Sir, we'll ask for the sir history regarding the pain associated any other symptoms like fever.
Now, what about pain?
But first, just pain. Try to understand. Pain is important to diagnose.
Yes, sir. Sir, we'll ask the site of onset of the pain, and sir duration of the pain. Then, sir, whether it is progressing, radiating to any other site, and sir, any relation to relation to meal or aggravating and relieving factors.
No, okay.
What
so
meal?
You say
you want relation to the meal, this pain or previous pain?
Previous pain, sir.
Try to understand. You are in emergency.
So when
you should take the patient detailed history to come to a diagnosis. We are not going into that.
Yes, sir.
So what kind of means? Just elaborate on the pain. Means what kind of pain do you expect? What? Okay. Let me ask you in another. Let me ask you in a different manner. Like suppose this patient has come with a generalized pain abdomen, right? Yes, so sir. Now what are the things that actually come to your mind? So then you will be able to focus on the pain that the patient is having.
Sir, generalized pain abdomen, sir, maybe due to peptic perforation, sir.
Okay, one next.
So then, sir,
so tell me the acute patients presenting with acute pain abdomen in an emergency.
Come on, diagnosis.
Yeah,
sir, acute pain abdomen is due to sir acute cholecystitis, sir. Then sir, peptic ulcer disease, sir. Then
think about the organs that are present in the abdomen. So yes, you have spoken about the gallbladder. You have spoken about the stomach and duodenum. Peptic ulcer means it encompasses stomach and duodenum. What else? Could it arise from the pancreas?
Yes, sir. Acute pancreatitis, sir. Then,
okay.
Sir,
could it arise from the appendix?
Yes, sir. Acute appendicitis.
Okay, so if you take all these things into consideration, each of them has got a particular characteristic of pain presentation, isn't it?
Yes, sir.
So that is what I am asking you. So what are the things you are going to ask? Suppose you say it's a case of peptic perforation. So how do you means what will be the nature of pain?
Sir, sir, it will be acute in onset.
Hmm.
Initially, sir, it was towards the epigastric region or right upper quadrant.
Yes. And then how does
Then,
it radiate?
then it radiate towards the, sir, right iliac fossa.
For peptic perforation or appendicitis?
For appendicitis, sir, pain will arise from the periumbilical region and radiate towards the right iliac fossa, sir.
Ah,
It goes along the right paracolic gutter. That is a restriction. If
Yes,
there is a
sir.
peptic perforation, pain in the upper quadrant goes along the right paracolic gutter and becomes generalized.
Yes, sir.
okay. So all and what is the particular thing that the patient can complain or you need to ask him about pain in case of peptic perforation? They will say that I was having a excruciating pain and then there was suddenly a history of something giving way. It might be present. It might not be present also, or it might be present. Okay. Okay. What else? What are the other things you need to ask?
Sir, we'll ask, sir, associated symptoms like fever, vomiting, sir. Then we'll look for the abdominal distension.
No. First, don't look for something. First, you ask something, then you look for something because that is a part of the examination, isn't it?
Yes, sir.
So in the history, you will ask about pain. You will characterize the pain, the localization of the pain, from where it started, the duration of the pain, right? And if there are any associated features that are there with the pain. Okay. So these are the things which are related to pain. Then you ask, you said, correct, okay, you will ask about vomiting. Okay. So that is also there. And then the nature of vomiters is also important.
Yes, sir.
Okay. So these are the things you ask about the pain. Now this is from the history of present illness. Now what about the past history?
The past history, we'll ask for previous history. For previous history of like use of and like sir, NSAIDs or sir history of use of
That means you ask about, you have written, say it is written intermittent episodes of pain abdomen. So that means he was having an intermittent episode of pain abdomen in the past also.
yes, sir.
So do you need to ask about any periodicity of that pain? Do you need to ask whether the patient was on any PPIs?
Yes, sir.
You said you'll ask about the history of NSAID. So is it very important in this gentleman, 30-year gentleman, or is it important in an elderly person?
Sir, in elderly person, sir.
Why?
Sir, they used to take NSAID
Yes, NSAID.
frequently
Because of
other
what
What
other?
indication? What are the important indication for chronic NSAID use? Which patient uses this? Patient of arthritis.
Yes.
arthritis.
So elderly patients, they usually suffer from arthritis.
Yes,
So they are habituated to taking NSAIDs, right? So the question of NSAID is important in case of elderly persons, not in persons, young patients. So this patient is 30 years of old. So for this patient, we need to ask about the periodicity. We need to ask about whether the patient is alcoholic whether the patient is habituated to smoking, whether the patient is taking PPIs. So these are important. Okay.
Yes, sir.
Okay. What else will you ask? Do you need to take anything, any other history? Because you are in the emergency. So when such a patient comes, based on only these two things, you cannot you cannot arrive at a diagnosis. So you need to ask something else also.
Sir, we'll ask for other to rule out the other causes of sir, like like frequent like history of frequent diarrhea in case of Crohn's or ulcerative colitis, and sir, we'll ask for the fever, weight of loss, loss, weight loss, and sir, loss of appetite.
Fever, weight loss, loss of appetite. Okay. So why do you ask about weight loss? Why do you
Sir,
ask about loss of appetite? What is in your mind?
sir, like sir, any sir, a small bowel perforation due to tuberculosis.
Small. No, why have you gone so down? Can something be there in the stomach also, which might lead to all these things and which might lead to perforation?
Yes, sir.
Yeah. So you should take a history of that also, isn't it?
Yes, sir.
So that is also important. Okay. So you need to take about history about the chronic illnesses that are present. So that is also important. You need to ask the patient about the characteristics of the stool, isn't it?
Yes, sir.
Why did you say yes, sir? What will you ask regarding stool?
Regarding stool, sir, we'll ask regarding the habits, sir, or the history of sir diarrhea, frequent history of diarrhea, sir.
So if you ask about frequent diarrhea, what is there in your mind?
Sir, maybe sir, in case of sir Crohn's disease, ulcerative
Is it
colitis.
very common? It is not that common, isn't it?
Yes, sir.
But related to peptic ulcer disease, which disease is more related to diarrhea? Though it is very rare, but still you have to think about it. Zollinger-Ellison syndrome, right?
Yes, sir.
So that you have to think about. Okay. So this is the history, and regarding stool, you will have to ask about whether the patient has got any melena, history of melena or not.
Yes, sir.
Right. So these are the things you need to ask in the history. Right. And also the characteristic of pain is very important. Apart from perforated peptic ulcer, the patient can have does not have typical features of peptic perforation, but the patient can suffer from diseases like pancreatitis. The patient can suffer from diseases like acute cholecystitis, as you have mentioned, and perforation can also occur in the gallbladder also. So all these things have to be kept in mind while you are taking the history. Okay,
Yes, sir.
coming to the examination now. So you said that on examination, you have a pulse of 134 per minute, respiratory rate is hurried, and then tachypnea is present and BP is low.
So patient is in shock.
Yes, sir.
Patient is in shock.
Yes, sir. Patient is in shock, sir.
Okay. So what do you think? You say is a situation of peritonitis with something else?
Sir, with peritonitis, sir, patient is in septic shock, sir.
Yes, might be.
Yes.
Only rigid abdomen will suffice, or do you want to see anything else apart from rigid abdomen?
Sir, apart from rigid abdomen, sir, we'll examine the sir.
Any clinical sign you want to see?
Sir, clinical. Sir, restriction of abdominal movement during respiration, and sir, liver
What about the tenderness? Will it be a localized tenderness, or you think it should be a patient having now generalized tenderness in the abdomen?
sir, patient will
Because
be
Peptic perforation, will this patient have a now localized tenderness, or you expect generalized tenderness in the abdomen?
sir generalized tenderness, sir.
Because already the abdomen is rigid and it
Yes,
might
sir.
be pain of some duration.
Yes, sir.
Can you find rebound tenderness?
Yes, sir.
So if the abdomen is too rigid, then rebound might be absent, right? So rebound tenderness, it depends on the time since when the patient has presented. So time is very vital.
Yeah.
Because
Yes.
if you aren't sure about the time, then means it's very difficult to decide what management you are going to give to the patient, right? And someone said
Percussion is
obliteration of
important.
the liver dullness, so that is also very important.
Yes,
So
sir.
percussion is important. Percussion, what do you like to achieve by percussion?
Sir, percussion tenderness, sir, we can see, and sir,
That is
we
one.
can,
What
we
else?
can, sir, we can check the liver dullness, sir, whether it is
And?
obliterated.
And
And-
can there be free fluid in the abdomen?
Yes, sir. Yes, sir. Sir, note will be, sir, uh,
So free fluid can also be present, isn't it?
yes, sir.
So see, the history is so important, means the nature of pain, the time of pain, and then you corroborate it with the abdominal findings. So you can have a rough idea as to how long the patient is suffering from this acute episode. So naturally, then seeing the blood pressure, the pulse rate, the respiratory rate, so you can have an idea about what is the condition of the patient. And then you need to plan accordingly.
Yes, sir.
Okay. So do you need to do a perrectal examination?
Um, sir, per rectal exam, yes, sir, will do, sir.
What will you find?
Sir, sir, per rectal sir, examination will look for the matlab, ballooning of the
Ballooning. Ballooning.
Ballooning will be there in obstruction, agreed, but in a patient who has got suspended peritonitis, what
Yes,
might be you eliciting on PR examination? You are talking of some free fluid in the abdomen. It can cause a pelvic collection.
yes, sir.
So what may be the finding on PR?
Sir, on PR, sir, rectal temperature may be raised, sir. And sir,
Rectal temperature. With a glad finger, you can assess the temperature.
no, sir. Sir,
Now, what is the most dependent part of the abdominal cavity?
sir, pelvis, sir. Pouch of Douglas.
Pouch of Douglas. Okay, right. So do
Sir,
you find anything there if you do a perrectal examination?
Sir, sir, if collection will be there, then sir, the feel will be.
No, not about feel. Okay, about feel, okay, you say feel will be there. Okay, take it. Before feel, something else will be there. The patient is having a rigid abdomen. There is rebound tenderness. There is free fluid in the abdomen.
So
Right.
rectal
The
examination will
patient
be
is in
tender.
shock.
Try to understand. If there's a pus in the pelvis, you do a rectal examination, it will be extremely tender.
Yes, sir.
And
Yes,
you
sir.
can see a bulge. You can feel a bulge in the rectum because of the pelvic collection. These are the two important findings.
Yes, sir.
So now you have this patient. Now you are inching towards a diagnosis of a perforative peritonitis. You have a patient who has got, okay, do you need to see anything else apart from whatever you have said? Any other physical findings you need to examine, which is very important in this patient? can you means does if the perforation is long standing, okay,
Yes, sir.
can you have anything looking at the face of the patient, can you have anything which can give you a clue?
Sir, long standing patient will be in severe septic shock, sir. Patient look will be toxic, sir.
Toxic, okay.
Yes, sir,
Anything
patient
else?
will be dehydrated, sir.
Huh?
Dehydration, signs of
Yeah,
dehydration.
yeah, yeah. So that is important, very important. So patient will be dehydrated. You need to ask about when he has passed urine, right? So this
Yes,
is important. Okay. So now you are means inching towards a diagnosis of a peptic perforation. Okay.
yes.
So do you need to do any investigations, or how do you plan now?
Sir, initially, sir, we'll resuscitate the patient at the same time, sir.
That's what I was waiting for. You should not send this patient for X-ray. His BP is 88. So
Yes,
in
sir.
emergency, parallel to your assessment, you should start the patient on IV fluid. What fluid you will start?
Sir, IV fluid, sir, we can start either a normal saline or ringer lactate, sir. Uh,
If the
Normal
patient was
saline or
vomiting too
ringal
much,
lactate?
suppose patient was vomiting too much. He
Sir,
has
then-
vomited 10 times. Will you start ringer lactate?
yes, sir.
Patient had number of episodes of vomiting. What is the metabolic status?
Sir,
If the patient got repeated episodes of vomiting, what
yes.
is the usual metabolic status?
Sir, hypokalemic.
Hyperkalemic.
Sir,
Or repeated vomiting.
Sir, hypokalemic, sir.
Hypokalemic
Sir, hypochloremic metabolic alkalosis, sir.
Another
and
thing you have
hypokalemic
missed.
also. So if you have metabolic alkalosis on the background of repeated vomiting, ringer lactate should not be started. It will aggravate alkalosis.
Yes, sir.
Okay, fine. You can start on a normal saline or ringer solution. Fine. Then
Sir, then, sir, we'll do, sir. Sir, we'll do Riles tube for this catheterization. Sir, sir, we'll start the IV antibiotics. Analgesic will give, sir.
Analgesic, what analgesic will you give?
Sir, opioids group, sir.
Huh? What is the dictum of suppose you means are you confirmed that this patient is having peptic perforation now? What is the dictum of giving analgesics in a patient with acute pain abdomen in an emergency? What is the normal dictum that is followed?
Normal dictum, sir.
The normal dictum is until and unless you have arrived at a specific diagnosis, you do not give analgesics which mask the effect of pain, and then you are lost in your diagnosis. So you are means allowed to give analgesics. Those analgesics which you have spoken about, that is the opioid analgesics, only when you have arrived at a diagnosis. So prior to arriving at a diagnosis, you are not supposed to give any analgesic which masks the pain. Means you can give IV fluids, you can give Riles tube, you can catheterize the patient, you can give antibiotics. You said antibiotics. What antibiotics will you prescribe?
Sir, antibiotics, sir, will start, sir. Sir, ceftriaxone, sir. Sir, metronidazole and sir, amikacin, sir.
so you should choose antibiotic which will cover gram
Broad
positive,
spectrum.
gram negative, and the bacterials. Okay, it's a polymicrobial infection here.
Yes.
Suspected peritonitis.
Okay, so you have put in a Riles tube, you have put in a catheter. What is the use? Why do you have? What is the use of putting in a catheter?
Sir, sir, will look for the urine output, and sir also for monitoring the sir output chart, sir. It will also indicate the whether the flu patient is properly resuscitated or not, sir.
So proper optimized, whether the patient is optimized or not.
Yes, sir.
Okay, and what is the use of giving a Riles tube?
Sir, Riles tube, sir, sir, it will decompress the stomach and sir also prevent the further vomiting and aspiration chance risk of aspiration, sir.
So how will it decompress the stomach? The stomach is already, there's a hole in the duodenum, isn't it? So air is going to pass through that too.
Yes.
So you prevent further, means vomiting, that you said, that is true, and that will prevent further aspiration which might occur, right? The other use why this Riles tube is put is it helps to certain extent. It's not true now, but what we used to do is when we were in a state of confusion whether it was a peptic perforation or not, so through that Riles tube you could give air or dye to note the perforation. So that was in yesterday's years, but nowadays we don't do it to that extent. Okay, so you have put in a Riles tube, we have catheterized the patient. Now the patient is optimized. Do you want to have an X-ray now?
Yes, sir. Sir, we'll do.
What X-ray?
Sir, we'll do chest X-ray with both dome of diaphragm, sir, in erect position.
Where will you look for in the? What will you look for, and where will you look for?
Pardon, sir. Sir.
You said you will do a chest X-ray, isn't it?
Yes, sir.
Why not an abdominal X-ray?
Sir, abdominal X-ray, sir, we can do, sir.
No, that was I asking. Suppose you have two patients. One patient has suspected intestinal obstruction, and one patient has a perforated peritonitis. You said you will do chest X-ray. Why? I not ask for abdominal X-ray in a patient who I am suspecting perforated peritonitis. You justify your answer. Why
Sir,
not abdominal X-ray in a patient of perforated peritonitis? Because if you ask for abdominal X-ray, often you will find the diaphragm is not there. Okay.
yes, sir.
So
Yes.
perforated peritonitis, you ask for a chest X-ray. For a patient of internal obstruction, you ask for abdominal X-ray. Why? What do you like to see in obstruction?
Sir,
In obstruction, what do you like to see?
sir, we'll look for sir air fluid level, sir,
Air fluid level
and sir,
and you like to see the gut shadow. Is it
sir,
the small gut, or is the small gut or large gut combined, or is it the large gut?
yes, sir.
Because that will may help you to come to a diagnosis of where is the site of obstruction.
Yes, sir.
Okay, so for perforated peritonitis, chest X-ray. For obstruction,
Hello, sir.
Sir, you are not audible. Sir, you are not audible.
Fine. What?
So Sahasar is disconnected.
Yeah, that is good. Okay, let me continue. Let him join. So, Nitesh, you said you will do a chest X-ray, isn't it? So what sir also said that you will do an abdominal X-ray also, right?
Yes, sir.
So
Yes,
what do you expect to find in a chest X-ray, or how will you do a chest X-ray? Means you need to advise, na? And
Yes, sir.
you will advise and go away, or you will accompany the patient to the radiology department and try to seize for something.
Sir, we'll ask for sir position of the patient. Sir, sir, we'll look for the sir free gas under the diaphragm, sir. For that, sir, we sir, patient should be in erect posture, sir.
So erect posture.
Yes, sir.
So where will you, suppose that the perforation is very small.
Yes,
So there is a chink of gas. So where do you look?
sir.
In the
Yes.
subdiaphragmatic space, you look. It's okay. But on which side? Medial or lateral? So first is it goes to the medial side. So if there is a very thin amount of gas, a chink of gas shadow will be seen on the medial side, right?
Yes, sir.
What you need to do is you need to accompany the patient and you need to, means it's very difficult sometimes to get the patient in an upright posture. So what you need to do is you need to just make the patient sit and
Yes.
you need to wait for a minute or two and then you take an X-ray. But sometimes you find that this gas under diaphragm is not visible also. In 25 to 30% of the cases, there is no gas under diaphragm.
Yes, sir.
Okay. And
Yes.
then abdominal X-ray, what do you find? If it is a very delayed perforation, then you will find a ground glass opacity type of a thing. Okay.
Yes, sir.
So these are the things. So you want to do an X-ray. Anything else you want to do?
Sir, apart from X-ray, sir.
What are the ground glass appearance suggest?
Sir? Hello, sir.
Yes, yes. What does the ground glass appearance suggest?
Sir, ground glass appearance suggests, sir, fluid in the peritoneal cavity, sir.
Yes, that means there is a fluid, not only fluid, it is a turbid fluid which is present.
Yes.
So turbid fluid usually gives rise to a ground glass appearance. Okay, so now you have done an X-ray. So you have found gas under diaphragm. Do you say gas under diaphragm or any adjective you want to add?
Pardon, sir? Sir?
Do you means when you say chest X-ray, what do you say? You find gas under diaphragm or you want to add any adjective to that gas?
On which shadow look like? In a patient who has got only a chink of gas shadow, that is one. Second is gas shadow with a fluid level. What does it indicate? One patient having only a crescentic gas shadow, another patient has crescentic gas shadow with a fluid level.
Yes, sir.
Does it suggest anything?
Fluid levels are suggestive of, sir, delayed perforation, sir.
Yes.
Patient.
Yes. So if you have a fluid level, that indicates patient has got fluid in the petrol cavity, suggestive of a perforative petrol of some duration.
Yes,
If you have
sir.
a chink of gas only, that indicates just a perforation. May not be there is good amount of fluid collection in the petrol cavity. Fine. I think we can pass on to management.
Ah. Yeah. So now you have this patient. You have taken the history, you have done all the investigation. It's a case of peptic perforation. So now what are you planning to do with this patient?
Do you need an ultrasound, Nitesh? If you
No,
have
sir.
a chest section,
No.
no. So
No.
once patient has got free gas and diaphragm, rigid abdomen, this patient does not merit further investigation.
Yes, sir.
You should go for definitive treatment.
Yes, sir.
Also, if you find that you don't have any free gas under diaphragm, but your clinical examination are suggestive of perforative peritonitis, means surgical abdomen, as we say,
Yes, sir.
then you require to take on certain other investigations.
Yes.
But if you have a evidence of free gas under diaphragm, there is no need of going in for other investigations, means other radiological investigation. Obviously, you need to do the baseline investigations and all the other, means sodium, potassium, and whatever is there, you need to do that.
Yeah.
Yes, sir.
Okay, now what will you do?
Sir, I'll send some basic routine basic investigation, like, sir, CVC should so look for the hemoglobin level, sir. We'll look for the, sir, WBC count.
Okay, you find that the hemoglobin level is low. Okay.
Yes, sir.
And there is also a gas under diaphragm. So now what will you do?
Sir,
And why? Once you put in a digestive, you find that there is some amount of blood which you aspirate, because the pressure is also low, the pulse rate is high, right? And there is also a chink of gas under the diaphragm. Now what will you plan?
Sir, we'll take patient for exploratory laparotomy, sir, and sir, we'll arrange the blood at the
Okay,
same
blood
time.
is arranged. You arrange blood is arranged. So you will take the patient for laparotomy.
Yes, sir.
So what will be your incision?
Sir, we'll start with midline incision. So depending upon the site, sir, we'll extend up and down, sir.
Good. It will be
Okay.
mid-midline incision.
Yes, sir.
And then diagnose and then extend incision as desired.
Yes,
Right.
sir.
So now once you have incised the abdomen, is there anything which you need to pay meticulous attention to?
Yes, sir. Sir, after opening the abdomen, sir, we'll look for the
No, while you are opening the abdomen.
On the background of free gas and diaphragm, can you appreciate something? Yes, my diagnosis is right.
yes, sir. Sir, there will be the gush of air. Sir, sorry.
Yes.
Yes.
Air.
Sometimes, not always, but sometimes means you need to train your ears at that point of time. Tell other people in the OT to be quiet, bit quiet, and then you just lend your ears there, and sometimes you can hear a gush of air coming up.
Yes,
It's usual with a big perforation. With small
Yes.
perforations, we usually do not have, but with larger perforations, we can hear. Okay. So now you have incised the abdomen, you have gone inside the abdomen.
yes,
So
sir.
now,
Sir, sir, the contaminated fluid and sir will be aspirated, and sir will look for the site of perforation. Sir, sir, after
where will you look for the site of perforation?
sir will start from the stomach, sir. And
Stomach
then, sir,
starts from the esophagus, isn't
sir,
it?
we'll look
And
for
ends in
the
the pylorus.
yes, sir. We'll look the distal stomach, sir. Start.
Right? You won't look in the proximal and the body of the stomach.
Yes, sir.
Huh? Yes, sir means?
Sir, we'll look for the body of the stomach, sir, antrum. Then,
Where does the peptic ulcer occurs commonly? If you suspect a
Commonest site
peptic
is
ulcer,
where?
sir, and
along the greater curvature, along the lesser curvature.
sir, towards the sir, less.
Towards the lesser curvature.
Towards the lesser curvature, yes. So
And
you
then
need
the next common site is duodenum.
Yes, sir.
So if you have a diagnosis, you will suspect the perforation site looking at something else also. What else you look for? There will be some. What do you find? Some white flakes?
Sir, the flakes will be there, sir. Yes, sir.
Yes.
So flakes will be there. So you have sucked and now you have found that there is a perforation in the duodenum. Okay.
Yes.
The
Yes, sir.
first part of the duodenum, anterior surface. Now on the background of what I said, means you have a patient who has got, you had aspirated some amount of blood and then the pressure is low, pulse rate is high. Okay.
Yes.
So in the backdrop of this, now what will you do? You have found the perforation. Now, what is in your mind? Why, how can this happen?
Sir, sir, it is happen. Sir, if it involves the, sir,
Involves the?
sir, gastroduodenal artery.
Yes. So what happens? Peptic ulcer, the anterior ones usually what? It perforates.
Yes,
The
sir.
posterior ulcers usually bleed,
Sir.
isn't it?
Yes, sir.
So that is the reason why I asked you. Okay. So now suppose, okay, now forget about that thing. So now you have found a perforation on the anterior part of the duodenum, right?
Yes, sir.
So now what will you do?
Sir, we'll do the sir. We'll do the primary repair of the sir perforation by Graham's patch repairs. Sir.
What is that patch?
Sir,
What is that
mental.
patch?
Sir, momentum. Sir, we'll take the free momentum.
Which part of the momentum? Momentum
Sir,
is huge, na?
yes, sir.
Momentum
We
is going
usually-
from stomach, going down and then coming back to the transverse column. Which part of the momentum will it take and over the perforated side?
So three part of the momentum.
Which part?
Sir, three
Yes.
part of the momentum.
Yeah, free momentum, which can be mobilized, and that too from the right side. You don't pull out a momentum which is there on the left side,
You
isn't
take
it?
the free margin momentum up here.
Ah.
What suture will you take? What suture will you use for closing the perforation?
Sir, we'll take, sir, polygalactine, sir, 20, sir. Or if stomach will be thin, then, sir, 30.
Is it the size of the material of the suture which is important?
Yes, sir. Usually take, sir, 20 Vicryl, sir.
20 Vicryl. So you need to take an absorbable suture, not a non-absorbable suture.
Yes.
Okay, then how will you take the sutures?
Sir, sir, we'll take usually three whites, sir, two at the sides and one at the center of the perforation, sir.
So in which direction?
Sir, along the axis of the
Perpendicular to the axis of the ulcer. Perforation.
Yes.
Right, along the axis if you take, then what will happen is there could be stenosis. So you take it perpendicular to the axis of the ulcer. How far away from the margin?
Yes, sir.
How far away from the margin of the ulcer? Perforation.
Sir, answer 0.5 centimeters.
So you will take a scale and then measure 0.5 centimeters.
Approximately.
No, is there any way of approximating it rather than doing it approximately? What you do is
The ulcer about maybe 5 mm ulcer perforated. So two corner stitches at the edge of the ulcer and one
Yes.
center stitch. That is the standard suture you take.
Yes, sir.
and
Which
one thing
suture you take first? Which suture you take first? Center one or the peripheral one?
Sir, the corner sutures will be tied first, and the central the suture at the center is at the last, sir.
no what you do is after you have detected the perforation, you take a hemostatic forceps, right? And then what you do is you try to roll the hemostatic forceps along the mucosa of the both duodenum, proximal and distal. What happens is sometimes the ulcer, the serosa usually perforates. So what
Yes.
we can see from above is only the serosa. We do not know how far the mucosa is ulcerated. So once you roll that hemostatic forceps along the mucosa, you can feel the margin of the mucosa. So you need to take the bites which are distal to that margin.
Okay, sir.
Okay.
Yes, sir.
Okay. So first you do it primary closure out and put in the patch, or you put in the patch and then you do close the sutures.
Sir,
What is the
sir,
classic page description?
sir, first,
Classic description is
sir, classic Graham's patch description is, sir, we'll first put the momentum and then take the knot.
yes.
Yes. So that is what is to be done. So you put the momentum and tie the sutures loosely so that you don't strangulate that piece of momentum which you have put in.
Yes, sir.
What is the patch is the Graham's patch, isn't it?
Yes, sir.
What is the name of the technique? Celan and Jones technique. You go through Hamilton belly, it is written there, right? So the patch is the Graham's patch and the technique is Celan and Jones technique.
Now
Okay.
you don't find a perforation. You explore, there is flakes around, but you cannot find a perforation in the anterior of the stomach and the duodenum. What next?
Sir, if we will not find the perforation, sir, then we'll sir, we'll look for the posterior surface of stomach and the duodenum, sir. Opening the sir, we'll open the laser sac by dividing the greater momentum, sir.
Okay, no perforation.
Gastrocolic momentum, not greater.
Momentum, sir.
No perforation seen now. What next?
Sir, if posterior surface, if there is no perforation in the posterior surface, then sir, we'll look for the other part of the sir.
What is the next common site of perforation?
Sir, we'll look for the sir, we'll look for the appendicular side, sir. Then, sir.
So you need to look at the appendix also.
Yes, sir.
Do you need to look at the small gut?
Yes, sir. We can. Yes, sir. We'll look for the gallbladder also.
Small gut?
Yes,
Appendix
sir.
normal. Appendix normal.
Sir, appendix normal, sir. Sir, we'll look for the small gut and sir, large large
You
bowel.
have to cut the whole small gut from
I have
BJ
given-
to ICG.
I had already given you a clue in the history, isn't it? Zollinger-Ellison syndrome.
Yes, sir.
So in
Yes, sir.
patients with ZD syndrome, you find a peptic ulcer with a simultaneous perforation somewhere else in the small gut also.
Yes. Sir.
So these are rare things, but these should be kept in mind.
Okay, sir.
Do you need to do a definitive surgery?
Sir, a definitive surgery, sir, can be done, sir, if patient will present early within 6 hours, sir. Patient general condition.
All patients.
Not
What are the
all.
indications of doing a definitive surgery in a patient with peptic perforation? Okay, you said if the patient presents early, but that is not a very definitive indication in these
Sir,
times, like where we have PPIs and everything.
yes, sir. Patient does not have medical illness for patient like
No, I'll
AFA.
tell you. I'll tell you. Suppose there is a big perforation in the duodenum, and you find that healthy duodenum cannot be achieved after closure, and there might be chances of stenosis.
Yes, sir.
So there you do a definitive surgery, one. Secondly, the intractable situation, which I said that there is a perforation associated with a bleeding which cannot be controlled.
Yes,
So
sir.
there you need to do a definitive surgery. Now these surgeries are gastrectomies, like gastrectomies and antrectomies, distal gastrectomies and antrectomies. And if you find this gentleman who is 30 years old, who has got an intermittent episode of pain abdomen, previously he was on PPI, and while you are doing, you find that the duodenum is scarred, and then you suspect that the patient can have a pyloric stenosis at a later date, then you need to do a definitive surgery, but then this surgery should be in the form of a vagotomy.
Yes, sir.
Okay.
Yes, sir.
So these are the three indications where you do, as far as your Hamilton belly is concerned, these are the three indications where you do a definitive surgery in case of patients.
And patient should be fit and surgery should be experienced.
Exactly. Yeah, that is.
Surgeon cannot venture for doing a vagotomy in acute setup.
Yes, sir.
You know, there's a very good maxim by Theodore Cocker regarding any emergency surgeries. You do whatever is necessary. Don't do whatever is not necessary.
Yes.
Means you do whatever is necessary, and means emergency is for saving the life of the patient. Now, okay, you have repaired it, right? Do you need to put in a drain now?
Yes, sir. We'll put drain, sir, in the hepatorenal pouch of Morrison, sir.
Okay, so you need to put in a drain also.
Yes.
Okay. Now, how will you? What will you? Now you have come to the patient has come to the ward. Post-operatively, the patient has done well. You have put the patient on normal diet, and the patient is now fit for discharge, right? So,
Yes,
what
sir.
advice will you give?
Sir, on discharge, sir, sir, we'll start
I
PPI.
usually give this advice because most of these peptic ulcer are H. pylori related.
Yes,
So
sir.
on discharge, can you give a anti-expectorant treatment for these patients?
Yes, sir.
So this is a chronic peptic ulcer which is perforated. These patients should be on long-term PPI.
Yes, sir. Long-term PPI.
But ulcer has to heal. So these patients should be on long-term PPI. And if you suspect that patient might have some acid H. pylori infection, you can give the patient H. pylori for 2 weeks.
How long will you give the PPI?
Sir,
Yeah.
sir, for sir, 8 weeks. Sir.
Yeah.
And after 8 weeks, you'll stop, or you need to have some maintenance dose. It does on peptic ulcers treatment 8 weeks.
Sir, 6 to 8 weeks, sir. Will give sir.
Books, the gastroenterology books have some discussion on this. Okay.
Yes, sir.
Ulcer might heal by 6 to 8 weeks.
Yes,
If the patient has got associated hyperchlorhydria or other factors, in that case, you might need to continue a maintenance dose of PPI.
Okay, sir.
Long-term PPIs are actually not indicated. You give it for 2 weeks, 2 months, and then depending on the situation, means you need to give.
Yeah.
Okay, sir.
Okay, Makunda, anything further?
I think we have covered it.
Yeah.
One question is, suppose on third post-op day, you find about 300 ml of bile stain fluid is coming.
Yes,
On
sir.
third or fourth post-op day, you find there is about 300 or 400 ml of bile stain fluid is coming. So what might have gone wrong?
Sir, sir, suture may be tied, or sir, we missed the other site of perforation.
What has happened? Initially, it was very less, and fourth or fifth post-op day, again, drain started coming with the bile stain fluid. So what might have happened to the patient now?
Sir, sir,
There might be a
other site of perforation.
No,
same perforation site.
same perforation.
Sir, momentum maybe the momental patch we put maybe.
Simple corona. There might be a reperforation.
Now, what is the chance of reperforation on the long-term basis? Can these, suppose you have put the patient on PPIs, right? You haven't done a definitive surgery. So can the patient have a reperforation at a later date?
Sir, sir, if we'll do definitive surgery, sir, chances will be less, sir. But like,
when you haven't done a definitive surgery.
yes, sir.
Yeah, so see, it is written in textbook that there can be chances of reperforation, and some textbooks have mentioned that it is as high as 60%, right? So, but means it's very difficult to say whether it will reperforate or not. And it was a belief, but means I am yet to see any peptic perforation reperforate.
Yes, sir.
Okay, thank you so much. Makunda, anything else?
Okay, thank you. Thank you. Thank you.
Thank you, sir.
Okay,
Thank you.
thank you.
Thank you, Dr. Uttade.
Happy New Year.
Happy New Year. Thank you.
Happy New Year, sir.
Okay.
Thank you, sir.